they put an A in it.
Yeah, it does. So this is chapter 33, orthopedic injuries. I'm going to skip through your competencies because you should know them by heart by now. And go straight to the intro. All right. Musculoskeletal injuries are one of the most common reasons patients seek medical attention. Complaints related to the musculoskeletal system affect more than 126 million people in the United States. Musculoskeletal injuries are often easily identified because of associated pain, swelling, and deformity. These are rarely fatal, often result in short or long-term disability. By providing prompt assessment and treatment, advanced emergency medical technicians may help reduce the disability period for patients. Do not focus solely on the injury without first determining that no life-threatening injuries exist. Never forget to assess the airway, breathing, circulation, disability, and exposure. As an advanced EMT, you must be familiar with the basic anatomy of the body's musculoskeletal system. Your A&P review. The musculoskeletal system gives the body its shape and allows for its movement. Movement is generated because muscles are attached to bones by tendons. When a muscle contracts, the force generated by the muscle is transferred to a bone on the opposite side of the joint from the muscle. Hematopoiesis is the process of generating blood cells. Muscles. They are composed of specialized cells that contract when stimulated to exert a force on a part of the body. The muscular system includes three types of muscles. This is cardiac, skeletal, and smooth. Skeletal muscle allows the body to maintain its posture and to sit or stand. Muscle contraction requires energy, which is derived from the metabolism of glucose and results in the production of lactic acid. Muscle innervation. Skeletal muscle is innervated by somatic motor neurons. The combination of the muscle and the neuron that innervates it constitutes a motor unit. Recruitment is to generate a more forceful contraction. More neurons are needed to signal more muscle cells to contract. Musculoskeletal blood supply. Skeletal muscle is supplied with arteries, veins, and nerves. It is important to realize which arteries are present in each part of the extremity. The blood supply in each upper extremity originates from the subclavian artery. This figure shows the arterial supply of the extremities. A is the upper extremity and B is the lower extremity. The skeleton. This protects our vital internal organs and allows us to move. It is made up of approximately 206 bones. It's divided into two distinct portions, the axial skeleton and the appendicular skeleton. The axial skeleton comprises the bones of the central part or axis of the body. The appendicular skeleton is divided into the pectoral girdle, the pelvic girdle, and the bones of the upper and lower extremities. The pectoral girdle consists of two scapula and two clavicles. The upper extremity extends from the shoulder to the fingertips and is composed of the upper arm, elbow, and forearm. The radius and ulna make up the forearm. Because these bones are arranged in parallel, when one is broken, the other is often broken as well. The hand contains three sets of bones. You have the wrist bones, which are the carpals, hand bones are metacarpals, and finger bones are the phalanges. The pelvis supports the body weight and protects the structures within the pelvis. You have the urinary bladder, the rectum, and female reproductive organs. The two iliac bones are joined posteriorly by tough ligaments to the sacrum at the sacroiliac joints. The two pubic bones are connected anteriorly by equally tough ligaments at the pubic symphysis. Each lower extremity consists of the bones of the thigh, leg, and foot. The lower leg consists of two bones, the tibia and the fibula. The fibula is an attachment point for the lateral ligaments of the knee joint. It also serves as the lateral stabilizer of the ankle joint at its distal articulation. The foot consists of three classes of bones. The ankle bones are the tarsals, foot bones are metatarsals, and toe bones are phalanges. A joint is formed wherever two bones come into contact, and those are the different types of joints there. The various motions that a joint may allow include flexion, extension, abduction, adduction, rotation, circumduction, pronation, and supination. Bone classifications, they are classified based on their shapes. Long bones are longer than they are wide. Short bones are nearly as wide as they are long. Flat bones are thin, broad bones. Irregular bones have complex shapes that are designed to perform specific functions. Sesamoid bones or round bones are generally found in tendons. Typical long bone architecture. Long bones can grow to such lengths because of the presence of the growth plate or physis in children. The long bone is divided into the diaphysis, epiphysis, and metaphysis, or metaphysis. Yeah. I'm trying my best not to get tongue-tied, y'all. I tried to record this earlier today, and I just can't. Like, today's one of these days I cannot talk, so bear with me. The area where two bones come in contact to form a joint is covered by a thin layer of articular cartilage. The portion of bone that is not covered by articular cartilage is instead covered by the periosteum. In the inner portion of the long bone, blood comes from the nutrient artery of the bone. Tendons, ligaments, and cartilage. Tendons connect skeletal muscle to the bone. Tendons cross joints to create a pulling force between two bones when a muscle contracts. Ligaments connect bone to bone and help maintain the stability of joints and determine the degree of joint motion. Cartilage consists of fibers of collagen embedded in a gelatinous substance. Age-associated changes. Bone density decreases after the age of 35 years. This leads to a loss of height and produces changes in facial structure. In women, the decrease in bone density accelerates once menopause is reached. A significant decrease in bone density, called osteoporosis, is associated with a higher risk of fracture. Aging of muscles, cartilage, and other connective tissues may also lead to degradation of joints and disc herniation. Patho. Musculoskeletal injuries may result from both blunt and penetrating trauma. Sports injuries account for a significant number of musculoskeletal injuries. Among children, intentional trauma or abuse is a common cause of fractures and musculoskeletal injuries. Pathologic fracture occurs when a medical condition causes the bone to become abnormally weak. Your mechanism of injury. Significant force is required to cause fractures and dislocations. This force may be applied to a limb in any of the following ways: direct blows, indirect forces, twisting forces, or high energy injuries. A direct blow fracture to the bone at the point of impact. A high velocity injury typically shatters the bone and causes extensive soft tissue damage. An impalement injury commonly causes a soft tissue injury similar to that seen in a low velocity penetrating injury. It is essential to stabilize the object to protect the soft tissues from further injury. An indirect injury occurs when force is applied to one region of the body but causes an injury in another region. Forces may be transmitted along the entire length of a bone or through several bones in series. A person falling on an outstretched hand may have one or more injuries as the result of forces transmitted proximally from the point of impact. They could have fracture to the scaphoid bone of the hand from a direct blow, a fracture to the distal ulna and radius, a fracture or dislocation of the elbow, fracture or dislocation of the shoulder, or fracture of the clavicle. Immediately identify the point of contact and the mechanism of injury to decrease the chance of overlooking any associated injuries. Twisting forces are a common cause of musculoskeletal injury. Some injuries are commonly encountered together because of the way the causative forces are transmitted. Refer to Table 33.1 in your book. Fractures. A fracture is a break in the continuity of a bone. Fractures occur when the magnitude of the force applied to the bone overcomes the strength of the bone. Types of fractures. They are classified as either open or closed. In an open fracture, sometimes called a compound fracture, a break in the overlying skin allows the fracture to be exposed to the outside environment. This allows much of the blood to escape. In a closed fracture, the skin over the fracture site remains intact. Blood loss may exceed 1 liter before enough pressure develops to tamponade the bleeding. When treating patients with possible fractures or dislocations, determine whether the overlying skin is damaged. Treat any injury that breaks the skin as a possible open fracture. Angulation of a fracture means that the bone is misaligned as a result of the injury and that an angle has formed between the fractured fragments. A non-displaced fracture is a simple crack of the bone that may be difficult to distinguish from a sprain or simple contusion. In a displaced fracture, the two bone ends at the fracture are separated in at least one plane. Medical personnel often use the following special terms to describe types of fractures. They are transverse, oblique, spiral, uh, comminuted, green stick, incomplete, pathologic, and epiphyseal. So those are the different types of fractures it shows you there in the picture. A green stick fracture, fun fact, this is going to be commonly found in children because their bones are more pliable and they still have a lot of cartilage. So that gets its name from, if you ever get a stick, like a twig, that's still very young, it's not like full wood, it's green, and when you go to try to break it, it kind of bends and splinters, but it won't, you can't break it in half, it's very, very hard. Do y'all know what I'm talking about when I say that? Yeah. Okay, so that's where this fracture gets its name from. You'll see a bowing of the arm or a bowing of the leg where the bone is bent and deformed, but not exactly broken. So that's where the green stick fracture gets its name from. Signs and symptoms of a fracture. Deformity is one of the most reliable signs. Shortening occurs in fractures when the broken ends of a bone override each other. Visual inspection will usually reveal swelling at the fracture site. As blood infiltrates the tissues around the broken bone ends, bruising will become apparent. Fractures are very often associated with ecchymosis of the surrounding tissues. A fractured bone is almost invariably tender to palpation over the fracture site. Point tenderness is tenderness that is sharply localized at the site of injury. Pain commonly occurs in association with fractures. Guarding and loss of use characterize most fractures. Guarding occurs when the muscles around the fracture contract to prevent any movement of the broken bone. Palpation may reveal crepitus, a grating sensation over the bone ends. False motion occurs at a point in the limb where there is no joint. A locked joint is difficult and painful to move. In an open fracture, exposed bone ends may be visible in the wound. Dislocations. A bone is totally displaced from the joint in dislocations. Dislocations occur when a body part moves beyond its normal range of motion. A dislocated joint may spontaneously undergo reduction before beginning assessment. A dislocation that does not spontaneously reduce is a serious problem. The partial dislocation of a joint is known as a subluxation. Signs and symptoms of a dislocated joint are similar to those of a fracture. You'll have marked deformity, swelling, pain that is aggravated by any attempt at movement, tenderness on palpation, virtually complete loss of normal joint motion, which is a locked joint, numbness or impaired circulation to the limb or digit. A dislocation is considered an urgent injury because of its potential to cause neurovascular compromise distal to the site of injury. Always assess the patient's neurovascular status distal to the site of location. What are we checking when we check neurovascular status? We're looking for PMS or CMS, pulse motor sensory or circulation motor sensory. Sprains are injuries in which ligaments are stretched or torn, usually result from a sudden movement of a joint beyond its normal range of motion. Signs and symptoms: point tenderness can be elicited over the injured ligaments. Swelling and ecchymosis appear at the point of injury to the ligament resulting from torn blood vessels. Pain causes the patient to be unwilling to move or use the limb normally. Instability of the joint is indicated by increased motion, and sprains rarely involve deformity. Strains are an injury to the muscle and or tendon that results from a violent muscle contraction or from excessive stretching. Only minor swelling may be noted at the site of injury. Achilles tendon rupture. A rupture of the Achilles tendon usually occurs in athletes older than 30 years involved in start and stop sports. The most immediate indications are pain from the heel to the calf and a sudden inability to perform plantar flexion of the foot. Acute management includes RICE, which is rest, ice, compression and elevation, and pain control. Long-term treatment may involve splinting or surgery. Amputations. Amputation is the separation of a limb or other body part from the remainder of the body. Hemorrhage from complete or incomplete amputations can be severe and life-threatening. Patient assessment. Attempts to splint and work to stabilize the patient's condition are very important. Do not become distracted by visually impressive injuries. Carefully assess the MOI to try to determine the amount of kinetic energy that an injured limb has absorbed. Maintain a high index of suspicion for associated injuries. Other priorities are identify injuries, prevent further harm and damage to injured structures and surrounding tissues, support the injured area, administer pain medication if necessary. In cases of musculoskeletal injuries, patients may be classified based on the presence or absence of associated injuries. This is life or limb-threatening injury or condition, life-threatening injuries and only simple musculoskeletal trauma, life or limb-threatening musculoskeletal trauma and no other life-threatening injuries, or isolated non-life-threatening or non-limb-threatening injuries. The golden hour is critical not only for maintaining life but also for preserving limbs. Any suspected open fracture or vascular injury is considered a medical emergency. You can identify critical injuries by using the musculoskeletal injury grading system, which is in Table 33-2 in your book. Scene size up. Information from dispatch may indicate the MOI, the number of patients involved, and any first aid procedures used prior to your arrival. The situation may change prior to your arrival at the incident. Observe for hazards. Try to identify the forces associated with the MOI. Evaluate the need and request early for law enforcement support, paramedic backup, or additional ambulances. Be alert for both primary and secondary injuries. Primary injuries are the result of the MOI. Secondary injuries are the result of what happens after the initial injury. Primary survey, focus on the patient's mental status, X, A, B, C, D, E's, and priority. Continue history taking and a secondary assessment in case of no life-threatening condition. If the patient has a significant MOI, then complete a rapid full body scan on scene and en route to the emergency department. Identify the injuries, prevent further harm or damage to the injured structures and surrounding tissues, and support the injured areas. Evaluate the patient's level of consciousness and orientation. Check for responsiveness using the IFPU scale. If the patient is alert, the information he or she provides should help direct you to any apparent life threats. If not alert, determine whether he or she responds to verbal or painful stimuli or whether he or she is unresponsive. An unresponsive patient may indicate a life-threatening condition. Administer oxygen as needed via a non-rebreathing mask to all patients whose level of consciousness is less than alert. If the patient was subjected to significant trauma and multiple body systems are affected, do not waste scene time on prolonged musculoskeletal assessment or splinting. Evaluate the chief complaint and MOI to identify open airway and adequate breathing. If a spinal injury is suspected, take the appropriate precautions and prepare for stabilization. Address exsanguating hemorrhage first, and then address airway and breathing concerns. Circulatory assessment should focus on determining pulse, adequate perfusion, and bleeding. If the skin is pale, cool, or clammy and capillary refill time is slow, treat the patient for shock immediately. Maintain a normal body temperature and improve perfusion by administering oxygen. Careful handling of the extremity minimizes this risk. If external bleeding is present, bandage the extremity quickly to control bleeding. Use sterile dressings to cover the wound and bone. If bleeding cannot be controlled, quickly apply a tourniquet. Provide rapid transport to the closest hospital in case of airway problems or significant bleeding. Handle fractures carefully while preparing the patient for transport. History taking. Investigate the chief complaint. After life threats have been managed, obtain medical history. Be alert for injury-specific signs and symptoms and any pertinent negatives. Obtain information from the patient and any bystanders who witnessed the accident or incident. Condition of the patient immediately before the incident. Details of the incident and patient's position after the incident. Ask the patient for a subjective description of injury. Your sample history. This should be obtained for all trauma patients. At the scene, you may have access to family members and others with information about the patient's history. Make attempts to obtain it without delaying time to definitive care. If time allows, identify pre-existing musculoskeletal disorders. Attempt to learn more about the injury. Use your OPQRST, which is onset, provocation, or palliation, quality, region, radiation, severity, and timing. Limit use with severe injury. It's time consuming when airway, breathing, circulation, and rapid transport require immediate attention. It may be useful when the MOI is unclear, the patient's condition is stable, details of the injury are uncertain, and evaluating the patient's pain. The patient may experience acute pain with musculoskeletal injury. Have the patient quantify the severity of pain by using a 1 to 10 pain scale or a pain scale that uses images of facial expressions. Secondary assessment. This is a more detailed, comprehensive exam of the patient that can reveal injuries that may have been missed during the primary assessment. More severe injuries increase when 2 or more bones have been broken. Physical exam is if significant trauma has likely affected multiple systems. Start with a full body scan to find all problems and injuries. Begin with the head and work systematically towards the feet. The goal is to identify hidden and potentially life-threatening injuries. This will also help to prepare for rapid transport. When examining a stable patient with an isolated injury, obtain a baseline set of vital signs. One of the simplest ways to assess an extremity is to compare one side with the other, noting any discrepancy in length, position, or skin color. Complete the secondary assessment by noting DCAT BTLS. While performing the exam, ensure you cover the 6 P's of musculoskeletal assessment. This is pain, paralysis, paresthesias, pulselessness, pallor, and pressure. Evaluate the circulation, motor function, and abnormal sensations. Consider distracting injuries, assess the entire zone of injury, and always evaluate the joint above and below the site of injury. Inspect for the following signs: deformity, skin changes, swelling, muscle spasms, abnormal limb positioning, increased or decreased range of motion, color changes, and bleeding. Palpation, palpate for tenderness. It may be the only significant sign of underlying musculoskeletal injury. Palpate regions above and below the injury site. Identify regions of point tenderness. Reassess tender areas. Attempt to identify instability, deformity, abnormal joint or bone continuity in displaced bones. Feel for crepitus. Palpate distal pulses on all extremities and pay special attention to comparing the strength of the pulses in the injured extremity with those in a normal one. Palpation of the pelvis. This is used to identify instability and point tenderness. Apply pressure over the pubic symphysis to evaluate for tenderness and crepitus. Press the iliac wings toward midline and then posteriorly. Report any gross instability to hospital personnel. Do not repeatedly examine the pelvis if instability is found. The examination of both extremities should include independently palpating the entire length of each arm and leg to identify any sites of injury. When you evaluate the upper extremities, always examine the cervical spine and shoulder. Neurovascular status. Injuries or deformities of a bone may be associated with vessel or nerve injury. Assess neurovascular function every 5 to 10 minutes during the care process. Always recheck the patient's neurovascular function before and after splaining. Failure to restore circulation situation can lead to death of the limb. To assess neurovascular status, follow the steps in Skill Drill 33-1. Evaluate an unresponsive patient's limb for deformity, swelling, ecchymosis, false motion, and crepitus. Vital signs. Determine a baseline set of vital signs. Baseline indicators must be obtained as soon as possible. Trends in vital signs can indicate whether the patient's condition is improving or getting worse over time. Shock or hypoperfusion is common in musculoskeletal injuries. Assess blood glucose levels in all patients with altered mental status. Reassessment. Repeat the primary assessment to ensure your interventions are working as they should. A reassessment should be performed every 5 minutes for an unstable patient and every 15 minutes for a stable patient. Interventions. Trauma patients often have multiple injuries. Assess all overall condition, stabilize ABCs, and control serious bleeding before treating the injured area. Consider calling early for paramedic backup if needed. Secure critically injured patient to long backboard to stabilize the spine, pelvis, and extremities. Provide prompt transport to the trauma center. Perform the primary survey at the scene. Provide rapid transport, reassessing the patient en route to the ED. If the patient has no life-threatening injuries, take extra time at the scene to stabilize obvious injuries and perform a more thorough evaluation. Report problems with the patient's ABCs, open fractures, and compromised circulation before and after splinting. In your documentation, give complete descriptions of injuries and the MOIs associated with them. This is crucial to assess and document the presence or absence of circulation, motor function, and sensation distal to the injury before moving an extremity. Always document the findings of a neurovascular exam, even if they are normal. When the abnormality is identified, document the specific deficit. Careful documentation may protect you from legal action if patients or their families pursue it later. Do not rely on your memory to recall details from situations. Emergency medical care. Your first steps in providing care for any patient are the primary survey and stabilizing the patient's ABCs. If needed, perform a rapid full body scan or focus on a specific injury. Always take standard precautions. Be alert for signs and symptoms of internal bleeding. Suspect whenever the MOI suggests that severe forces have affected the body. Follow the steps in Skill Drill 33-2 when caring for patients with musculoskeletal injuries. Volume deficit due to musculoskeletal injuries. Fractures may lead to significant blood loss from damaged blood vessels within the bone. Implement interventions such as applying direct pressure, splinting, and administering IV fluids to prevent the development of hypotension and an unstable condition. Table 33.3 lists the potential amount of blood loss from various fracture sites. The goal of pre-hospital management should be to keep the fluid volume, vital signs, and mental status normal. Administer fluids in 20 milliliters per kilogram increments to maintain blood pressure and perfusion. Cold and heat application. Cold packs are useful for treating patients during the initial 48 hours following an injury. Effective at decreasing pain and swelling, causes vasoconstriction of the blood vessels in the region, decreases the release of the inflammatory mediator. Heat therapy should be avoided during the initial 48 to 72 hours following an injury. It may increase pain and swelling during this period. It's useful for increasing blood flow to the region to decrease stiffness and to promote healing. It's beneficial for patients who report an injury that occurred several days before contacting EMS. Splinting. A splint is a flexible or rigid device used to protect and maintain the position of an injured extremity. Unless the patient's life is in immediate danger, splint all fractures, dislocations, and sprains before moving the patient. Splinting reduces pain and the risk of further damage to muscles, nerves, blood vessels, and skin. In addition, splinting helps to control bleeding. A splint is simply a device to prevent motion of the injured part. When no splinting materials are available, the patient's arm can be bound to the chest wall, an injured leg can be bound to the uninjured leg. The three major types of splints are traction splints, rigid splints, and formable splints. The best way to stabilize multiple fractures in a critical condition is to splint the axial skeleton using a long backboard and straps or an alternative device. This protects against a spinal injury, reduces movement of the injured extremities by securing them to a board, and saves time at the scene. Principles of splinting: remove clothing from the area of any suspected fracture or dislocation so that you can inspect the extremity for decap BTLS. Assess and record the patient's neurovascular status distal to the site of the injury. Cover all wounds with a dry, sterile dressing before splinting. Do not move the patient before splinting an extremity unless there is an immediate hazard to the patient or yourself. For fractures, the splint should immobilize the bone ends and the two adjacent joints. For dislocations, the splint must extend along the entire length of the bone above and the entire length of the bone below the dislocated joint. Pad all rigid splints to prevent local pressure and discomfort to the patient. Manually support the injured site with hands placed above and below the injury. If a long bone fracture is severely angulated and no pulse is present in the extremity, gently apply longitudinal traction. Do not attempt to straighten fractures involving joints without first obtaining medical direction. If the patient reports severe pain or is resistant to movement, discontinue applying traction, splint the joint or bone in the position of deformity. Carefully monitor the distal neurovascular status. If possible, avoid covering the fingers and toes with the splint. If possible, apply cold packs and elevate the splinted limb to minimize swelling. Stabilize all suspected spinal injuries in a neutral inline position on the long backboard. If the patient has signs of shock, align the limb in the normal anatomic position and provide transport. When in doubt, splint. This is a National Registry skill and splinting, like it said on this slide, but we're going to go over it again. If you are splinting a bone, you are going to splint the joint above and below that bone. If you're splinting a joint, you're going to splint the bone above and below that joint. Okay? Everybody got that?
Yes, ma'am. Yes.
Okay. Be aware of the hazards associated with the improper application of splints, which include the following: compression of nerves, tissues, and blood vessels, delay in transport of a patient with a life-threatening injury, reduction of distal circulation, aggravation of the injury, injury to tissue, nerves, blood vessels, or muscles due to excessive movement of the bone or joint. Traction splints. Application of inline traction is the act of pulling on a body structure in the direction of its normal alignment. It is the most effective way to realign a fracture of the shaft of a long bone so the limb can be splinted more effectively. Following a femur fracture, the strong muscles of the thigh go into spasms. Traction splints prevent the broken bone ends from overriding due to unopposed muscle contraction. Traction splints help maintain alignment of the fractured pieces and provide effective stabilization of the fracture site. Blood loss is reduced. Excessive traction can be harmful to an injured limb. Do not attempt to reduce the fracture or force all the bone fragments back into alignment. In the field, the goals of inline traction are as follows: to stabilize the fracture fragments, to prevent excessive movement, to align the limb sufficiently to allow it to be placed into a splint, and to avoid potential neurovascular compromise. Use the least amount of force necessary. The direction of traction pull is always along the long axis of the limb. It helps if a second person can support the injured limb directly under the site of the fracture. Traction splints are used primarily to stabilize isolated fractures of the mid-shaft femur. Do not use a traction splint if the patient has a joint or lower leg injury. Traction splints are not suitable for use on the upper extremities. Do not use traction splints in patients with any of the following conditions: injuries close to or involving the knee, injuries of the pelvis, partial amputations or avulsions with bone separation, lower leg, foot, or ankle injury. To apply a hair traction splint, follow the steps in skill drill 33.3. Hair traction splint stabilizes the limb by producing counter traction on the ischium and in the groin. Avoid excessive pressure on the external genitalia. The Sager traction splint is lightweight, easy to store, and applies a measurable amount of traction. To apply a Sager traction splint, follow the steps in skill drill 33-4. Rigid splints. Rigid is non-formable, and they are made from firm material. Oops, sorry, touching too much stuff. They are made from firm material and are applied to the sides, front, and/or back of an injured extremity to prevent motion at the injury site. It takes 2 advanced EMTs to apply a rigid splint. Follow the steps in skill drill 33-5 to apply a rigid splint. There are 2 situations in which you must splint the limb in the position of deformity. That is when the deformity is severe or when you encounter resistance or extreme pain when applying gentle traction to the fracture of the shaft of the long bone. Apply padded board splints to each side of the limb and secure them with soft roller bandages. Most dislocations should be splinted as found, but follow local protocols. Attempts to realign or reduce dislocations can lead to more damage. Pneumatic splints. These are useful for stabilizing fractures involving the lower leg or forearm. They are not effective for angulated fractures or for fractures that involve a joint. Air splints are most commonly used pneumatic splint, available in a variety of sizes and shapes. Always inflate after applying it. It has the added advantage of applying firm pressure to help control bleeding and reduce swelling. It should not be used on open fractures in which any sharp bone ends are exposed. All open wounds must be covered with a dressing before applying these splints. Prone to cold weather, overinflation can occur when the splint is applied in a cold area and the patient is subsequently moved to a warmer area. Carefully monitor the splint and let air out if the splint becomes overinflated. To apply a zippered air splint, follow the steps in skill drill 33-6. To apply an unzippered air splint, follow the steps in skill drill 33-7. Pneumatic anti-shock garments, or PASGs, situations in which use of a PASG is allowed vary widely by locale. Contraindicated for treatment of shock. Do not use the PASG if any of the following conditions exist: pregnancy, pulmonary edema, acute heart failure, penetrating chest injuries, groin injuries, or major head injuries. Inflate all the compartments if you are using the device to stabilize a possible pelvic fracture. Do not remove a PASG in the field. This should be removed in a hospital. Report the patient's blood pressure, the time you applied the PASG, and the results to the hospital personnel. Formable splints. Formable, formable splints include the following: vacuum splints, pillow splints, structural aluminum malleable or SAM splints, sling and swab, and pelvic binders. A vacuum splint can be easily shaped to fit around a deformed limb. Follow the steps in skill drill 33-8 to apply a vacuum splint. Pelvic binders. These are meant to provide temporary stabilization until definitive stabilization can be achieved. This should be light, made of soft material, and easily applied by one person. Be familiar with the manufacturer's instructions for your specific device. Buddy splinting. This is used to splint injuries that involve the fingers or toe. To buddy splint, tape the injured digit to an uninjured one. Place a gauze pad between the digits that are taped together and ensure the tape is not so tight as to cut off circulation. I know y'all are tired of talking about splinting. All right, transportation. Very few, if any, injuries justify the use of excessive speed during transport. The limb will be stable once a dressing and splint have been applied. A patient with a pulseless limb must be given a higher priority. If the hospital is a few minutes away, speeding will make no difference to the patient's eventual outcome. If the treatment facility is an hour or more away, a patient with a pulseless limb should be transported by helicopter or immediate ground transportation. If circulation in a distal limb is impaired, consult medical direction. Pathophysiology assessment and management of complications of musculoskeletal injuries. Musculoskeletal injuries can lead to numerous complications. It is essential to not focus all of your attention on the musculoskeletal injury. The likelihood of developing a complication is often related to the strength of the force that caused the injury location, and the overall health. The greater the force that caused the injury, the greater the hemorrhage that will be associated with it. To prevent infection following an open fracture, brush away any debris on the skin surrounding an open fracture before applying a dressing. Do not enter or probe the open fracture site to retrieve debris. Long-term disability is one of the most devastating consequences of a musculoskeletal injury. Administer analgesia and transport patients with musculoskeletal injuries to an appropriate medical facility. Peripheral nerve and vascular injuries. When blood vessels are damaged following a musculoskeletal injury, the patient may experience devascularization. Neurovascular injuries can occur additionally. Critical structures typically lie deep within the limb and close to the skeleton. Displaced fracture fragments may lacerate or impale nerves, leading to a neurologic deficit. Neurovascular injuries are also likely to occur following a joint dislocation. It is important to assess and reassess pulses, control bleeding, and maintain adequate intravascular volume. Compartment syndrome. The fascia confines muscles to an enclosed space or compartment. Compartment syndrome is one of the most devastating consequences of a musculoskeletal injury. The longer this situation persists, the greater the chance for tissue necrosis. Both external and internal factors can lead to the development of compartment syndrome. Open fractures have a higher risk of compartment syndrome because they are typically associated with higher energy injuries. I'll get it out in a minute. Compartment syndrome usually develops within 6 to 12 hours after injury. It is characterized by severe pain that is localized to the involved compartment. Skin pallor may be apparent as well as paresthesias. Another late sign of compartment syndrome is absence of distal pulses in the affected extremity. If a patient has a fracture below the elbow or the knee, ask about the following: extreme pain, decreased pain sensation, pain on stretching of affected muscles, decreased strength. The goal of pre-hospital care is to deliver the patient to an emergency facility before the extremity is pulseless. Management should include elevating the extremity to the heart level, placing ice packs over the extremity, and opening or loosening constrictive clothing and splint material. Administer oxygen and crystalloid solution as needed. Consider administering nitrous oxide for pain management as allowed by local protocols. Frequently reassess the patient's neurovascular status during transport. Compartment syndrome must be managed surgically. Crush syndrome. Crush syndrome occurs when a prolonged compressive force impairs muscle metabolism and circulation following the extrication or release of an entrapped limb. Rhabdomyolysis is tissue necrosis, leads to release of harmful products. After a muscle is compressed for 4 to 6 hours, muscle cells begin to die and release their contents into the localized vasculature. Treatment of crush syndrome should always be performed with medical direction. Assess the ABCs, administer supplemental oxygen as needed, consider administering a bolus of crystalloid solution, and do not apply a compressive device such as PASG. Thromboembolic disease. This includes deep vein thrombosis or a DVT and pulmonary embolism. These are significant causes of death. Signs and symptoms of a DVT include disproportionate swelling of an extremity, discomfort in an extremity that worsens with use, warmth and erythema of the extremity. When a DVT dislodges, it may cause a pulmonary embolism. Signs and symptoms of a pulmonary embolism include sudden onset of dyspnea, pleuritic chest pain. What do we mean by pleuritic chest pain? Somebody, anybody.
I'm thinking.
So pleuritic chest pain, if you'll remember your medical terminology, pleura refers to the lungs. So a pleuritic chest pain is going to be a pain that's not associated with the heart. It's not a cardiac. It's associated with lung pain. So burning in the chest, sharp pains when you take a deep breath. Those are signs of a pleuritic chest pain. All right, dyspnea, tachypnea, tachycardia, right-sided heart failure, shock, and cardiac arrest. Patients with long bone or pelvic fractures are at risk for development of fat embolism syndrome. Treatment for fat embolism syndrome in the field is limited to maintaining the airway, adequate oxygenation, and intravascular volume, and rapid transport to the ED. All right, fractures of the scapula or shoulder blade occur much less frequently because the bone is well protected by many large muscles. Fractures of the scapula are almost always the result of violent, direct trauma to the back directly over the scapula. It may also injure the thoracic cage, lungs, and heart. Carefully assess the patient for signs of pneumothorax, hemothorax, and rib fractures. Provide supplemental oxygen and prompt transport for patients who are having respiratory difficulty. It is the associated chest injuries, not the fractured scapula itself, that pose the greatest threat of long-term disability. Abrasions, contusions, and significant swelling may occur, and the patient will often limit use of the arm because of pain at the fracture site. The scapula has bony projections that may be fractured with a lesser degree of force. The joint between the lateral aspect of the clavicle and the acromion process of the scapula is called the acromioclavicular or AC joint. This joint is frequently separated during football or hockey when a player falls and lands on the point of the shoulder, driving the scapula away from the outer end of the clavicle. This dislocation is often called an AC separation. The distal end of the clavicle will usually stick out. The patient will report pain, including point tenderness over the AC joint. Fractures of clavicle and scapula and AC separations can be effectively splinted with a sling and swab. Sling is any bandage or material that helps support weight of injured upper extremity, relieving downward pull of gravity on the injured site. To effectively apply sling, use gentle upward support to the olecranon process of the ulna. The knot should be tied to one side of the neck so it does not press uncomfortably on the cervical spine. To fully immobilize the shoulder region, a swab must be used to bind the arm to the chest wall, tight enough to prevent the arm from swinging freely, but not so tight as to compress the chest and compromise breathing. Leave fingers exposed so you can assess neurovascular function. Commercially available shoulder immobilizers or slings will provide adequate spleening for injuries of the shoulder region. Dislocation of the shoulder, the glenohumeral joint or the shoulder joint, is where the head of the humerus meets the glenoid fossa of the scapula. The glenoid fossa joins with the humeral head to form the glenohumeral joint. It is the most commonly dislocated large joint in the body. The humeral head most commonly dislocates anteriorly. Shoulder dislocations are extremely painful. The patient will guard the shoulder and try to protect it by holding the dislocated arm in a fixed position away from the chest wall. The shoulder joint will usually be locked and the shoulder will appear squared off or flattened. The humeral head will protrude anteriorly underneath the pectoralis major and the anterior chest wall. The axillary nerve may be compressed. Document this finding. Some patients may report numbness in the hand because of compromise of the nerves or circulation. Stabilizing an anterior shoulder dislocation will produce pain. Splint the joint in whatever position is most comfortable for the patient. If necessary, place a pillow, rolled blankets, or rolled towels between the arm and chest to fill space. Once the arm is stabilized, the elbow can usually be flexed to a 90-degree angle without causing further pain. Apply the sling to the forearm and wrist to support the weight of the arm. Secure the arm in the sling to the pillow and chest with a swab. Transport the patient in sitting or semi-seated position. Dislocation of shoulder disrupts supporting ligaments of anterior aspect of the shoulder. Dislocation recurs because these ligaments often fail to heal properly. It may cause further neurovascular compromise and joint injury. Surgical repair may be required. Some patients can reduce or set their own dislocated shoulders. A shoulder dislocates posteriorly instead of anteriorly about once in every 20 cases. The arm will often be locked in adducted position towards the midline so it cannot be rotated. Reducing the dislocation usually requires medical supervision. Fractures of the humerus. Fractures of the humerus may occur either proximally in the midshaft or distally at the elbow. Fractures of the proximal humerus result from falls. These are common among older adults. Fractures of the midshaft occur more often in young patients, usually as the result of a violent injury. Examine the extremity to reveal any significant swelling, ecchymosis, gross instability of the region, and crepitus. The radial nerve may be injured by the force itself or become entrapped within the fracture site. The classic sign of a radial nerve injury is wrist drop. If the fracture is angulated, longitudinal traction may be applied to correct the deformity. Once the extremity is in the desired position, apply a rigid splint that extends from the axilla to the elbow. Compartment syndrome can develop in the forearm in children with these fractures. Elbow injuries, fractures and dislocations often occur around the elbow, and the different types of injuries are difficult to distinguish without radiographs. Refer to Table 33.4. However, they all produce similar limb deformities and require the same emergency care. Injuries to nerves and blood vessels are quite common in this region. Care of elbow injuries, they are serious and require careful management. Assess distal neurovascular function periodically. If you find strong pulses and good capillary refill, splint the elbow in position in which you found it. Apply 2 padded board splints to each side of the limb and secure with soft roller bandages. Alternatively, you can mold a padded wire ladder splint or SAM splint to shape the limb. If necessary, add further support to the limb with a pillow. Cold, pale hand, or weak or absent pulse and poor capillary refill indicate that blood vessels have likely been injured. Further care must be dictated by a physician. Consult medical direction immediately. If you are within 15 minutes of the hospital, splint the limb in position in which you found it and provide prompt transport. Otherwise, medical control may direct you to try to realign the limb. If the limb is pulseless and significantly deformed at the elbow, apply gentle manual traction in line with the long axis of the limb to decrease the deformity. Assume any deformity in proximity to a joint in children younger than 16 years is a growth plate injury. Fractures of the forearm. Fractures of the shaft of the radius and ulna are common in people of all age groups, but are seen most often in children and older people. Usually both bones break at the same time when the injury is the result of a fall on an outstretched hand. A Colles fracture. Um, this is a fracture of the distal radius. It's especially common in elderly patients with osteoporosis. Let me go back up. An isolated fracture of the shaft of the ulna may occur as the result of a direct blow to it. It is known as a nightstick fracture. The term silver fork deformity is used to describe the distinctive appearance of the patient's arm. That's going to be with a Colles fracture. In children, this fracture may occur through a growth plate and can have long-term consequences. To stabilize fractures of the forearm or wrist, you can use a padded board, air vacuum, or pillow splint. If the shaft of the bone has been fractured, ensure to include the elbow joint in the splint. Splinting of the elbow joint is not essential with fractures near the wrist. The patient will be more comfortable if you add a sling or pillow for support. If possible, elevate the injured extremity above the heart to help alleviate swelling. Injuries of the wrist and hand. Injuries of the wrist, ranging from dislocation to sprains, must be confirmed by radiographs. Dislocations are usually associated with a fracture. Another common wrist injury is the isolated, non-displaced fracture of a carpal bone, especially the scaphoid. Any questionable wrist sprains must be splinted and evaluated in the ED or an orthopedic surgeon's office. Hand injuries vary widely and some have potentially serious consequences. All hand injuries must be evaluated promptly by a physician. Do not attempt to pop a dislocated finger joint back in place. Always take any amputated parts to the hospital with the patient. Wrap in dry or moist sterile dressing, depending on local protocol. Place in a dry plastic bag. Put the bag in a cooled container. Do not soak the part in water or allow it to freeze. Follow the steps in Skill Drill 33-9 to splint the hand and wrist. Fracture of the pelvis, relatively uncommon injuries accounting for fewer than 3% of all fractures, is responsible for a significant number of deaths in blunt trauma patients. Death after a pelvic fracture results from massive hemorrhage. Disruptions of the pelvic ring occur secondary to high energy trauma, such as crash injuries, motorcycle crashes, and falls from significant height. A number of structures within the pelvis are at risk for injury when it is fractured. These include the bladder, urethra, rectum, vagina, sacral nerve plexus, veins within the pelvis, internal or external iliac and arteries in the lumbar region, nerves in the lumbar and sacral regions, and sciatic and femoral nerves. Fractures of the pelvis may be accompanied by life-threatening loss of blood from the laceration of blood vessels affixed to the pelvis at certain key points. Up to several liters of blood may drain into the pelvic space and the retroperitoneal space. Take immediate steps to treat shock, even if there is only minimal swelling. Often there are no visible signs of bleeding until severe blood loss has occurred. Be prepared to resuscitate the patient rapidly if this becomes necessary. Patients with pelvic ring disruptions who have stable injury may report pain in the pelvis and difficulty bearing weight. Patients with more severe injury may show evidence of profound shock, gross pelvic instability, diffuse pelvic and lower abdominal pain. There may also be bruising or lacerations in the perineum, scrotum, groin, suprapubic region, and flank. Hematuria, which is blood in the urine. Blood coming from meatus of penis, vagina, or rectum. Lateral compression pelvic ring disruptions result from an impact on the side of the body. The side of the pelvis that sustains the impact becomes internally rotated around the sacrum. The actual volume within the pelvis decreases. This is often associated with injuries in other regions of the body. These figures show a lateral compression injury to the pelvis and the radiograph of a lateral compression injury. Anterior-posterior compression pelvic ring disruptions may occur following head-on MVC, motorcycle crash, fall, or pedestrian struck head-on by vehicle. The force of impact compresses the pelvis in an anterior to posterior direction. It causes the pubic symphysis and posterior supporting ligaments to be disrupted and tear apart. The pelvis then spreads apart and opens like a book. Open book pelvic fracture is what this is called. Potential for massive blood loss. Vertical shear, major forces applied to the pelvis from above or below. On landing, the force is transmitted through legs and pelvis. It leads to complete displacement of one or both sides of the pelvis towards the head. Anterior and posterior components. Anterior component is fracture of rami or disruption of symphysis pubis. Posterior component is fracture of ilium or sacrum or disruption of the sacroiliac joint. The patient is likely to have significant shortening of the limb on the affected side and risk for massive hemorrhage into the pelvis. Straddle fracture. This occurs after a fall when a person lands in the region of the perineum and sustains bilateral fractures of inferior and superior rami. It does not interfere with weight bearing, carries risk because of associated complications. Open pelvic fractures. These are life-threatening injuries defined by the presence of a laceration of skin in the pelvic region, vagina, or rectum. They are uncommon, caused by a high-velocity injury with subsequent massive hemorrhage. Even small amounts of blood found during vaginal or rectal exams should raise your suspicion for an open fracture. Care of pelvic fractures. Suspect a pelvic fracture if the patient has sustained high velocity injury and experiences discomfort in the lower back or abdomen. Deformity or swelling may be difficult to see. The most reliable sign is simple tenderness on firm compression and palpation. Firm compression on two iliac crests will produce pain at the fracture site in the pelvic ring. Assess for tenderness by taking the following steps. Place the palms of your hands over lateral aspect of each iliac crest. Apply firm but gentle inward pressure on the pelvic ring. With the patient lying supine, place palm over the anterior aspect of each iliac crest. Apply firm downward pressure. Use the palm to firmly but gently palpate the pubic symphysis. The area will be tender if there is injury to the anterior portion of the pelvic ring. Once you have identified significant tenderness or any instability, further pressure on the pelvis for the purpose of examination is contraindicated. With injury to the bladder or urethra, the patient will have lower abdominal tenderness and may have evidence of hematuria or blood at the urethral opening. Perform a primary survey. Carefully monitor the general condition. Treatment should include monitoring of ABCs, spinal immobilization, IV access with at least one large bore catheter. Management involves reducing the amount of bleeding and decreasing degree of instability. Often appropriate to seek medical direction, especially to determine how to best stabilize the pelvis. Methods include application of PASG or pelvic binder or tying a sheet around the pelvis. Once immobilized on a long backboard, the patient should be rapidly transported to the trauma center. Administer IV fluids to maintain adequate tissue perfusion, which is radial pulses, and avoid hypertension. Dislocations of the hip. Hip joint is a very stable ball and socket joint, dislocates only after significant injury. Almost all dislocations are posterior. The femoral head is displaced posteriorly to lie in muscles of the buttock. Suspect hip dislocation in any patient who has been in an MVC and has a contusion, laceration, or obvious fracture in the knee region. Femoral head rarely dislocates anteriorly. Why are we going to suspect a hip dislocation if they have a knee injury?
Because if it pushes up, like if the knee was pushed up, then it's gonna like detach the hip.
Right, that
Not
energy
detach
is,
it necessarily, but you know what I mean.
yeah. So that force and that energy is going to travel upward from the knee to the hip. The femoral head rarely dislocates anteriorly. Legs are suddenly and forcibly spread wide apart and locked in this position. Posterior dislocation of the hip is frequently complicated by injury to sciatic nerves. Most important nerve in the lower extremity. It controls activity of muscles in the thigh and below the knee and sensation in the entire leg and foot. When the head of the femur is forced out of the hip socket, it may lead to partial or complete paralysis of the nerve. It generally only dorsiflexors are involved, and this causes foot drop. Patients with posterior dislocation of the hip typically lie with the hip joint flexed. That means the knee joint is drawn up towards the chest. The thigh rotated inward towards midline of the body over the top of the opposite thigh. With the less common anterior dislocation, the limb is in the opposite position, extended straight out, rotated, and pointing away from the midline of the body. Distinctive signs: severe pain in the hip, strong resistance to any attempt to move the joint. Lateral and posterior aspects of the hip region will be tender on palpation. With some thin people, femoral head deep within the muscles of the buttock can be palpated. Check for sciatic nerve injury. Assess sensation and motor function in lower extremity. Occasionally, function will be normal at first, then slowly diminish. Do not attempt to reduce the dislocated hip in the field. Splint the dislocation in position of deformity. Place the patient supine on scoop stretcher or long backboard. Support the affected limb with pillows and rolled blankets, particularly under the flexed knee. Secure the entire limb to backboard with long straps so that the hip region will not move. Provide prompt transport. Fractures of the proximal femur. Uh, Fractures of the proximal or upper end of the femur are common fractures, especially in elderly people. These are usually called hip fractures. They rarely involve the hip joint. The break goes through the neck of the femur. The intertrochanteric, I can't get that out, intertrochanteric or middle region, or across the proximal shaft of the femur, which is the subtrochanteric fracture. It occurs most often in older adult patients, particularly patients with osteoporosis, but may also be seen as a result of high energy injuries in young patients. Patients display a very characteristic deformity. They lie with the legs externally rotated, and the injured leg is usually shorter than the opposite uninjured limb. When the fracture is not displaced, the deformity is not present. Patients typically are unable to walk or move the leg. The hip region is usually tender on palpation, and gentle rolling of the leg will cause pain but will not do further damage. On occasion, pain is referred to the knee. Assess the pelvis for any soft tissue injury and bandage appropriately. Assess pulses and motor and sensory function, looking for signs of vascular and nerve damage. After assessment, splint the lower extremity of an elderly patient who has fallen and reports pain in the hip or knee, even if there is no deformity. Transport to the emergency department. The age of the patient and severity of the injury will dictate how to splint the fracture. Geriatric patient with isolated hip fracture does not require traction splint. All patients with hip fractures may have significant blood loss. Administer oxygen as needed, monitor vital signs frequently, be alert for signs of shock, and initiate IV therapy. Femoral shaft fractures. Fractures of the femur can occur in any part of the shaft, from the hip region to the femoral condyles just above the knee joint. Following a fracture, the quadricep muscles begin to spasm. The muscle spasms often produce significant deformity of the limb. Usually the limb also shortens significantly. Fractures are occasionally open and fragments of bone may protrude through the skin. Do not attempt to push the bones back into the skin. Patients often experience significant blood loss at the fracture site. Damage to the neurovascular structures of the thigh is possible. Continue to watch for the onset of hypovolemic shock. Cover any wound with a dry, sterile dressing. If the foot or leg below the level of the fracture shows signs of impaired circulation, apply gentle longitudinal traction to the deformed limb in line with the long axis of the limb. Gradually turn the leg from the deformed position to restore the limb's overall alignment. If this does not restore or improve circulation to the foot, the patient is in need of prompt medical attention. Managing femoral shaft fractures include monitoring for evidence of shock, full spinal mobilization, and establishing vascular access. Consider calling for paramedic backup to administer pain medication if it will not delay transport to a trauma center. Knee injuries. The knee is very vulnerable to injury, therefore many different types of injuries occur in this region. Ligament injuries range from mild sprains to complete dislocation of the joint. The patella can also dislocate. What is the patella?
The knee bone. Here.
The kneecap.
Yeah.
All the bony elements of the knee can fracture. Assess the patient's knee to reveal any significant findings. Injuries of the knee, ligaments. Knee is especially susceptible to ligament injuries, often seen in recreational and competitive athletes. Ligaments on the medial side are most frequently injured. Dislocation of the knee. The ligaments that provide support to it may be damaged or torn. More urgent injury is to the popliteal artery. Daniel, where's the popliteal artery?
I'm not stupid, I'm just panicking. That's in the foot, isn't it?
Nope.
No.
Maddie, where's the popliteal artery?
Behind the knee.
Thank you. The direction of dislocation refers to the position of the tibia with respect to the femur. Commonly, the anterior and posterior ligaments are damaged. There is also a high risk of injury to the popliteal artery. Daniel, where's the popliteal artery?
Stacy, I can't see your screen.
Behind the knee.
Okay. Can anybody else see my screen?
I can see it. I can see it, but it's small. Like, I don't know why, but Daniel's thing is like over everything.
Okay. You probably have him pinned, Tiff.
So mine is at the top, but it's completely black.
Go out and come back in, Kim.
I'm good now, thank you.
You're welcome. Okay, commonly the anterior and posterior ligaments are damaged. There's also a high risk of injury to the popliteal artery. In posterior dislocations, a direct blow to the knee forces the tibia to shift posteriorly. Medial dislocations result from a direct blow to the lateral part of the leg. Patients with a knee dislocation will typically report pain in the knee and report that the knee, quote, gave out. If adequate distal pulses are present, splint the knee in the position in which you found it and promptly transport the patient. Do not attempt to manipulate or straighten any severe knee injury if there are good distal pulses. On rare occasions, medical direction may instruct you to realign a deformed pulseless limb. You should make only one attempt to do this. Notify medical direction of the status of the distal pulse so arrangements to treat the patient can be made in advance. Fractures about the knee. These may occur at the distal end of the femur, at the proximal end of the tibia, or in the patella. It is easy to confuse a non-displaced or minimally displaced fracture about the knee with a ligament injury. A displaced fracture about the knee may produce significant deformity that makes it look like a dislocation. If the patient has a good distal pulse, then splint the extremity in the position in which it is found. Elevate the leg to the heart level and apply cold packs. Frequent neurovascular checks are mandatory. Continue to monitor the distal neurovascular function en route to the hospital.
I have a question.
Okay.
So is like realigning a pulseless extremity like Cat B, or is it like you just call and be like, hey, it's pulseless? Do you want me to do this? Like,
Yeah, it's going to be category B. You're going to call and get orders, and they're going to tell you how to do it and if you should even attempt it. The only time they're going to tell you to attempt it is if it is pulseless or if it's not perfusing to the point that it should be. And that's also going to depend on your proximity to the hospital. If you're pretty close, they're not going to let you mess with it. But they'll give you step-by-step direction on what to do to attempt to reduce that. I'm not sure if it's in your book. I know in the paramedic book it goes into detail on how to reduce fractures and dislocations. But you, again, only have one attempt to do that in the field because you can mess a lot of stuff up. But yes, you're going to call for orders and direction on exactly what to do depending on the joint and if they want you to attempt or
okay.
not. Dislocation of the patella. A dislocated patella most commonly occurs in teenagers and young adults who are engaged in athletic activities. Minor twisting may be enough to produce the problem. The displacement of the patella produces a significant deformity in which the knee is held in a slightly flexed position. The patella is displaced to the lateral side of the knee. Splint the knee in the position in which you found it. To immobilize the knee, apply padded board splints to the medial and lateral aspects of the joint. Occasionally, as you apply the splint, the patella will spontaneously return to its normal position. Report the spontaneous reduction as soon as you arrive at the hospital. Injuries of the tibia and fibula. The tibia, known as the shin bone, is the larger of the two leg bones that are responsible for supporting the major weight-bearing surface of the knee and ankle. The fibula is the smaller of them. Fracture of the shaft of the tibia or the fibula may occur at any place between the knee joint and the ankle joint. Usually both bones fracture at the same time. Even a single fracture may result in a severe deformity with significant angulation or rotation. Open fractures of the tibia are common. Stabilize with a padded, rigid, long leg splint or air splint that extends from the foot to the upper thigh. The affected leg should be secured to the opposite leg. Correct severe deformity before splinting. Apply gentle longitudinal traction. Restore a position that will take a standard splint. These fractures are sometimes associated with vascular injury. Realigning the limb frequently restores an adequate blood supply to the foot. If it does not, transport promptly and notify direction control en route. That was worded funny. Ankle injuries. Ankle fractures usually result from sudden forceful movements of the foot. An axial load is transmitted through the foot and causes the talus to impact the distal tibia, leading to a fracture. Signs and symptoms include pain, deformity, and swelling. Stabilize ankle fractures using a commercially available splint or a pillow splint. Leave the toes exposed to allow for frequent checks of distal neurovascular function. Elevate the extremity to the heart level and apply cold packs to reduce swelling. Okay, let's make sure they didn't need permission. Tiffany, going back on what you asked. Okay, so I'm recording this as we're lecturing and I got ahead of myself. So this may be on here twice or the wrong slide, but bear with me, it'll come together. So to reduce a fracture dislocation of the ankle, relax the calf muscle by flexing the patient's leg at the knee to allow the foot to move more freely. Rotate the foot back into its normal position without forcing it. Reassess the distal neurovascular status and splint the extremity in the reduced position. If you are unable to reduce the fracture dislocation, notify medical direction, splint the ankle in the position it was found, and provide rapid transport. Now, foot injuries. These can result in the fracture of tarsals, metatarsals, or phalanges of the toes. Toe fractures are especially common. Of the tarsal bones, the calcaneus, which is the heel bone, is most frequently fractured. Injury usually occurs when the patient falls or jumps from the height and lands directly on the heel. The force of the injury compresses the calcaneus, producing immediate swelling and ecchymosis. Frequently, the force of injury is transmitted up the legs to the spine, producing lumbar spine fracture. If you suspect that the foot is dislocated, immediately assess the patient's pulses and motor and sensory function. Injuries to the foot are associated with significant swelling, but rarely with gross deformity. Vascular injuries are not common. Lacerations about the ankle and foot may damage important underlying nerves and tendons. Puncture wounds of the foot are common and may cause serious infection if not treated early. All of these injuries must be evaluated and treated by a physician. To splint the foot, apply a rigid padded board splint, air splint, or pillow splint. Leave the toes exposed so you can periodically assess neurovascular function. When the patient is on the stretcher, elevate the foot approximately 6 inches to minimize swelling. All patients with lower extremity injuries should be transported in the supine position to allow for elevation of the limb. Never allow the foot and leg to dangle off the stretcher onto the floor or ground. If the patient has fallen from a height and reports heel pain, use a long backboard to stabilize any possible spinal injury. Amputations. Surgeons can often reattach amputated parts. Correct pre-hospital care is vital to successful reattachment. With partial amputations, ensure to immobilize the part with bulky compression dressings and a splint to prevent further injury. Do not sever any partial amputations, which may complicate later reattachment. Hemorrhage from amputations can be severe and life-threatening. Control bleeding and treat for shock. Control bleeding to the stump. If bleeding cannot be controlled, quickly apply a tourniquet just above the site of amputation. Make every attempt to preserve an amputated part in optimal condition. With a complete amputation, wrap the amputated part in sterile dressing and place in a plastic bag. Follow local protocols regarding how to preserve amputated parts. Put the plastic bag in a cool container filled with ice. Float the bag containing the right part on a bed of ice water. Do not pack it in ice. Keep the part cool without allowing it to freeze or develop frostbite. Do not warm an amputated part. Do not place an amputated part in water. Provide rapid transportation to the appropriate facility. When a limb or part of a limb has been amputated, notify the ED in advance of the type of case you are transporting and your estimated time of arrival. Consider administering a bolus of isotonic crystalloid solution if the patient has experienced significant blood loss or is hypotensive. Be aware of the patient's emotional stress, which can lead to psychogenic shock. Sprains and strains. It is best to err on the side of caution and treat every severe sprain as if it were a fracture. General treatment is similar to that of fractures and includes the following: rest, immobilize or splint the injured area, ice or cold pack over the injury, compression with an elastic bandage, elevation, splinting, reduce or protected weight bearing, pain management as soon as practical. Strains are treated in the same way as sprains. Okay, that's it for orthopedic. Do we got any questions?
I'm good.
I'm good.
I'm good. Good.
All right.